Hey everyone, welcome back to another condition-specific video. My name is Nathan and I'm a massage therapist at Parkland College. Today, I'm going to be going over the condition patellofemoral pain syndrome. This condition is moderately frequent, particularly in the athletic population. If you're a track runner or maybe even a football player, there's a good chance that you might have heard of this. So, what is patellofemoral pain syndrome? Well, it's a disorder of the extensor mechanism of the knee, which includes the quadriceps group, patellar tendon, femur, tibia, patella, and fascia. Clients often describe the pain as coming from under the kneecap, but are unable to identify a specific area. The site tissue under the patella are not necessarily the cause of the pain, as other tissues could refer pain to the region. Pain can be sharp at times, but is generally non-specific aching that improves with rest and is aggravated with activity. So it's kind of easy to see how athletes are affected by this condition. So if the client asks about anterior knee pain associated with activities emphasizing knee flexion and extension, such as running, jumping, climbing, or descending stairs, and even hiking, activities that all engage more resistance are likely to create more pain. You should ask your client about sudden changes in activity level, as for symptoms like these can be very harsh on the body. There's really no visible sign specifically for patellofemoral pain syndrome. However, certain biomechanical or postural distortions can play a role in this condition. Especially important is the presence of squinting patella or a large Q angle. As a result of pain and reflex muscular inhibition, some muscles atrophy rapidly. In particular, anti-gravity muscles such as the quadriceps atrophy faster than other muscles. Visual evaluation of extensor muscle dysfunction can be accomplished by measuring the circumference of the distal quadriceps with a flexible tape measure and comparing it to the opposite side. If there is a discrepancy, muscle atrophy is probable on the smaller side, which this measurement does not specifically identify patellofemoral pain syndrome. It does indicate a problem that is causing the quadriceps to atrophy, and patellofemoral pain syndrome may play a role in this condition. So now if we're talking about palpation, in some cases it is difficult to reproduce the pain of patellofemoral pain syndrome, while in other cases it's easy. For example, if the pain is due to irritation of the subchondral bone on the underside of the patella, light or moderate palpation anywhere around the knee does not always produce pain. However, when the patella is pressed against the femoral condyles, pain could be elicited by placing pressure. As I said before, if the knee is in flexion, pain will be exaggerated as the tissues are stretched from the quadriceps. So now let's talk about active range of motion. Pain is possible during active knee flexion or extension. Pain is greater if these movements are performed in a weight-bearing position, such as squatting during flexion or extension with either weight-bearing or non-weight-bearing positions is typical, as seen as in the video. Now I'm going to perform passive range of motion. Pain is unusual with passive movement unless the condition is advanced. Crepitus might be evident with flexion or extension. Pain is sometimes felt at full flexion as anterior knee tissues such as the patellar tendon and the extensor muscles are stretched. Now I'm going to be doing resistance testing. Pain is possible with resisted knee extension. Pain is more probable as the patella moves during active resisted extension and not during an isometric contraction. Reflex muscular inhibition can cause a quadriceps contraction to appear weak as the muscles decrease contraction strength in response to pain. The clip you're seeing now is me performing the patellar mobility test. The practitioner pushes the edge of the patella, attempting to move it medially and laterally. If the patella moves less than 1/4 of the patella's width in a medial direction, there may be restriction to proper tracking. The clip you're seeing now is me performing the Clark sign special test. I put my hand just over the superior side of the patella, right in between the suprapatellar tendon, and push straight down towards the table. The client slowly contracts the quadriceps until a full contraction is achieved. Pain is a positive result for the patellofemoral dysfunction. I'm now going to start the treatment process. I begin warming the tissue by using some effleurage techniques. Then I will do deep longitudinal stripping, sweeping, and superficial cross-fiber methods, broadening techniques, or even active engagement to help accomplish the goal in helping the client.